America's overdose crisis now claims over 100,000 lives every year, a staggering human cost that exceeds the toll of car crashes and gun violence. Each death is a son or daughter, a friend or parent, gone too soon. Yet this devastation is not for lack of medications, knowledge, or funding. We have effective treatments and proven harm reduction tools. What's missing is the leadership to organize these assets into a functioning system. The truth is harsh. The country does not lack resources. It lacks oversight, governance, and a blueprint that coordinates the resources already on hand. Consider the scale of resources we do have. States are beginning to receive more than $50 billion from opioid lawsuit settlements earmarked for abatement efforts. At the federal level, an array of 19 agencies already operates with roughly $44 billion dedicated to addressing addiction and the overdose epidemic. We have tens of thousands of treatment programs, first responders equipped with naloxone, and decades of research on what works. Money, programs, and knowledge exist. What we lack is a unifying strategy to deploy them coherently. No single entity ensures that all these efforts work in concert. No standard blueprint guides counties and states on how to build an effective continuum of care. The fragmentation means even well-intended efforts leave gaps through which people fall into tragedy. In short, we suffer not from scarcity, but from disorganization. The overdose crisis is a failure of management, not imagination. Worse, some current policy moves are undermining care when we need to bolster it. A glaring example is the recent federal decision effectively cutting Medicare reimbursement rates for physicians, which include addiction treatment and mental health providers. In late 2023, the administration finalized a Medicare payment rule that reduces physician payments by over 3% for 2024. Officials claimed they were improving payment for primary care and access to mental health care, but the reality is a blunt cut in provider funding. Medical groups warn that this substantial reduction dangerously impedes beneficiary access to care. Think about that. Amid an addiction epidemic, we are slashing the very reimbursements that clinics and counselors rely on to serve patients. This is more than a budgeting quirk. It's a policy choice that prioritizes short-term cost savings over lives. By shrinking the support for those on the front lines, we shrink capacity for treatment at the worst possible time. The signal such moves send is chilling. Despite all the rhetoric about fighting the opioid crisis, when it comes to actually financing care, we're moving backwards. These missteps underscore a broader pattern of deferred responsibility. Leaders declare addiction a priority, but when hard choices arrive, funding treatment, sustaining programs, expanding coverage, the commitment wavers. The result is a patchwork of efforts with no central accountability, easily unraveled by budget cuts or political shifts. So what would a serious, results-driven response look like? It would start by accepting responsibility for coordination. That means establishing strong oversight structures that insist on outcomes. Imagine a standing interagency council, health, housing, justice, education, labor, meeting regularly not for press conferences, but for problem solving. Its mandate, make the system deliver. Such a council would maintain live dashboards tracking key metrics across the community. How long does it take for a person who asks for help to get into treatment? Are we retaining people in care after 30, 90, 180 days? How many overdoses were reversed this month, and in what neighborhoods? How many people found stable housing or jobs in recovery? These outcomes should be measured and visible to all. Data would be broken down by race, gender, age, and location to spot inequities and direct resources accordingly. An accountable system makes its performance transparent, not to assign blame, but to drive improvement. With shared dashboards, everyone from agency heads to community members can see what's working and what's not. And when the numbers flag a problem, the oversight body acts. If overdose clusters spike in one district, the council assigns a response team immediately. If treatment slots aren't being filled, they find out why by Friday, not in a report next year. In this model, governance keeps attention honest. Metrics are reviewed in standing meetings, and someone is responsible for every target. This is serious systems thinking, treating the crisis with the same rigor we demand in a disaster response or a business turnaround. You manage what you measure, and right now, we are measuring far too little. It's time to replace vague promises with clear scorecards and real accountability. Next, a truly coordinated system ensures continuity of care at every turn. Break the cycle of people being dropped after the first outreach or first visit. It starts with the simplest principle: no warm handoff, no discharge. For example, when someone survives an overdose and lands in an emergency room, that cannot be a missed opportunity. A responsible protocol would start treatment immediately, initiate buprenorphine or methadone to ease withdrawal and cravings, and then hand off that patient directly to a community clinic the same day. The ER staff doesn't just say, "follow up someday." They call a specific treatment provider, arrange transportation, and ensure the person leaves with a follow-up appointment and even a bridge prescription in hand. Likewise, when a person is released from jail or prison, it should never be into a void. In too many places today, individuals with substance use disorder walk out of custody at 5 a.m. with a plastic bag of belongings, no ID, no medications, and nowhere to go. An almost guaranteed setup for relapse or overdose. A system with true continuity would do the opposite. Before release, it would start or continue medications for opioid or alcohol use disorder and make a plan with the individual. On release day, that person would have identification and insurance activated, a specific appointment time at a clinic, a peer or case manager to meet them at the gate, a phone already set up with important numbers, and a ride or transit pass to get to housing or treatment. In other words, an unbroken chain of care, not dramatic. They are simply decisive in keeping people alive and engaged. Every transition from hospital to clinic, jail to community, street to shelter, should be an orchestrated handoff, not a cliff edge. When continuity is the norm, fewer people fall through the cracks in those critical, vulnerable moments. Lives are saved in those handoffs. We know how to do this. It's a matter of making it standard practice everywhere. Third, we must protect and align funding to what works, instead of the boom and bust cycles that plague addiction initiatives. Far too often, a pilot program shows promise, maybe a new mobile clinic or a peer support initiative, but then its grant runs out, and the program collapses just as it was gaining trust. This is the typical short memory of our system, and it's deadly. We need to end the start and stop approach. If a pilot saves lives, scale it up. Make it permanent policy, not a temporary experiment. Budgets should reflect long-term commitments to successful interventions. That means building protected funding streams for core services, so they aren't subject to yearly whims. Essential life-saving efforts like naloxone distribution, syringe access, outreach teams, and housing support must have stable financing, the same way we fund fire departments or emergency rooms. You can't run an effective response on uncertain money. It's time to use the influx of settlement funds and existing public dollars in a coordinated way. Blend health, housing, and employment funding to support comprehensive programs. For example, combine healthcare dollars with housing dollars so that a housing-first program comes with case managers and medical support attached. Use opioid settlement money not for fleeting publicity projects, but to invest in infrastructure that survives beyond a grant cycle. Things like data systems, treatment facilities, and workforce training. And critically, tie funding to outcomes. Demand more of programs than just good intentions. Pay for results like retention and treatment, reductions in overdose, infections treated, stable housing attained. If a program is getting the job done, it should grow. If not, funding should shift to those that can. By aligning dollars with evidence, we stop wasting time and start reinforcing success. In practical terms, this might mean redesigning contracts and reimbursement models so that providers are rewarded for keeping people healthy, not just for billable visits. It also means ensuring that when federal or state budgets tighten, addiction and mental health services are walled off from cuts, protected just as we protect military readiness or Social Security. We cannot end an epidemic by funding it one fiscal year at a time. A working blueprint requires sustained investment and the courage to budget for the outcomes we say we want. Finally, any system is only as good as the people on the front lines. Invest in the workforce, the peers, clinicians, counselors, and outreach workers who turn plans into reality. We ask these professionals to take on one of the toughest challenges in public health, yet we often underpay them, undersupport them, and then wonder why turnover is high and capacity is low. It's time to treat these workers as the critical infrastructure they are. This starts with training and continues with ongoing support. Every clinician in primary care should be trained in addiction medicine and trauma-informed care, so help is available at every door. Similarly, peer support specialists, people with lived experience who guide others, should receive certification, decent wages, and a career ladder, not just gig work. These peers and counselors often form the trust bond that keeps someone in recovery. Investing in them is investing in success. We must also ensure manageable caseloads so that case managers and social workers can actually solve problems instead of rushing through dozens of clients. Frontline staff need more than praise, they need backup. That means fielding enough team members so no one is put in unsafe situations alone, and building in decompression time and mental health support for staff who deal daily with trauma. Burnout prevention should be a core design principle. Offer predictable schedules, ensure coverage when someone is ill or needs a break, and pay people on time for the hard work they do. If we continue relying on underfunded, emotionally exhausted workers and volunteers to prop up the system, it will continue to crumble. But if we invest in building a stable, skilled workforce through competitive pay, professional development, and emotional support, we create continuity for patients as well. Programs that budget for people will retain institutional knowledge and compassion. Programs that run on fumes will keep losing both. In short, treat the healers and helpers as assets to be nurtured, not expenses to be minimized. This is how we ensure that when someone reaches out for help, there is a capable, caring person there to answer. All of these changes are specific and actionable. None are magic. They are matters of design and political will. We know what components work. Many communities have pilot-tested pieces of this puzzle with success. The overdose epidemic can be tamed with steady, unglamorous work. Building data systems, tightening coordination, following through on every patient, funding what proves effective, and supporting the people doing the labor. The remaining question is whether we will finally take responsibility for knitting these pieces together nationwide. Year after year, we have watched this crisis escalate and responded with partial measures, slogans, or fleeting initiatives. That won't suffice. What's needed now is serious implementation of a comprehensive strategy, one that treats this emergency with the level of coordination and commitment we'd muster for any other threat taking 100,000 American lives a year. It requires public officials to move beyond speeches and hold themselves accountable for outcomes. It requires us as a society to decide that preventable overdose deaths are intolerable and to organize our systems accordingly. In the end, it boils down to a simple moral choice about responsibility. We have the resources, the knowledge, and the tools to drastically reduce this carnage. It's not resources we lack, it's responsibility we keep deferring.